Okay, now we are moving on to inflammatory disorders of the pediatric patient. Now remember, we're not just focusing on infants and toddlers. Those of you who are on the adolescent floor, you'll see there's a lot of chronic illnesses, and they do impact infants, toddlers, school age, but they impact your adolescents as well. So let's talk about Crohn's disease. You should be somewhat familiar with this from your medical surgical. It is considered an inflammatory disorder. It's also considered an autoimmune disorder. Signs and symptoms are abdominal pain, diarrhea, anorexia, and weight loss. You may also see growth and sexual development delay. Arthralgias, if you recall, that's pain in the joints. Arthritis, which is inflammation with stiffening, inflammation within the joints. Stomatitis, sorry about my spelling error there. Ulcers, inflammation of the eye, renal stones, and rashes on shins. So those kind of odd symptoms, that's what kind of clues you in that this isn't just an inflammatory disorder, this is also an autoimmune disorder. And while it mainly affects the abdominal, the intestinal system, it impacts other areas such as the eye, the kidneys, and the skin. So what's the nursing care? Well, first off, while it is not curable, it is managed pharmacologically. So what is our responsibility as the nurse? To assess for the need for medications, administer the medications on an appropriate time schedule, education to patients about the medications, what to watch for, and you are to monitor, assess for the effectiveness or adverse reactions to medications. Sometimes these medications suppress the immune system, and it can bring a whole nother group of problems along with them. So nursing care during medicational treatment is important. Nutrition. If you think about it, they're going to have anorexia. That means lack of an appetite. They don't feel hungry, they have no desire to eat, especially if it's going to cause more abdominal pain and diarrhea. In addition to not eating, what they do eat is rushing right on out. So nutrition is important. Bland, non-spicy foods. Have them keep a journal of their diet to determine what seems to aggravate their abdominal pain and diarrhea and what seems to not. Typically anything with seeds is avoided. Those kinds of things. So nutritional education, plus really stressing and educating on what's high calorie, high nutrient dense foods, rather than wasted calories and or low calories. So you can anticipate sometimes there will be some surgical care. Because it is an inflammatory disease, parts of the intestine can become so inflamed they can actually become necrotic, where they can be so swollen that an impaction occurs or a blockage and they lose part of the bowel. It's not unheard of with Crohn's disease to have an ileostomy or a colostomy due to loss of the intestinal tract, or just to rest the intestinal tract because it has become so inflamed. Rather than taking the risk of losing part of that bowel, they will put an ileostomy in and give the bowel a rest. And then emotional support, especially with the school age and the adolescent. Remember, this is the time of bullying. This is that developmental time in school age when kids are really looking at what's different. And different is not okay in the school ager. Now the adolescent, different is starting to be okay, but it still has to be cool and normal. Having a colostomy or an ileostomy or having embarrassing diarrhea in a public bathroom can be very difficult for the pediatric patient. So being in the hospital and having to use the bedside commode or the bedpan, and having a nurse that's only 5-6 years older than you can be very embarrassing for the adolescent patient. So keep that in mind, provide lots of emotional support, be available to listen. If they say something that's odd or just seems kind of sad, you want to give them a therapeutic response. It sounds like you're really struggling with that. Why don't you want to tell me about it? I can listen. I may not be able to fix it, but I can listen for you. That kind of communication. Okay, so moving on from Crohn's disease, ulcerative colitis. Again, it's inflammatory. Abdominal pain. In this instance, you have bloody diarrhea. And the clue is in the word ulcerative. And ulcerative is like an open, sore wound, just like a pressure ulcer, like a ulcer, a stomach ulcer. They do bleed. So abdominal pain, bloody diarrhea, urgency, meaning that they're not going to be able to hold it. Tenesmus, it's a spasmodic contraction of the anal sphincter with pain, is another symptom of ulcerative colitis. You may also see arthritis, arthralgia, oral ulcers, liver inflammation, skin lesions, and a rash. So what's the nursing care? What's our responsibility as a nurse? Understand that this disease can come and go. They'll go into remission for a while and may never come back, or it may come back frequently. Helping them to journal, to decide what triggers exacerbations, what puts them in remission, how do you prevent another exacerbation. The goal is that they continue to grow, and they try to have a normal lifestyle. Again, just as with Crohn's, there is the chance that they may have to have bowel surgery, portions of the bowel removed, or giving the bowel total rest with ileostomies or colostomies. They also can keep that exacerbation response suppressed with steroids, and you want to ensure they're getting sufficient nutrition. I just said the word steroids, and I want you to remember that because whether it's Crohn's disease or ulcerative colitis or any other autoimmune where the child is placed on steroids, I want you to think there's weight gain, water retention, acne, thinning hair, and a big puffy moon face, and potentially the puffy buffalo or hump or widow's hump, that are all side effects of high-dose steroid use. Bad enough if you're an adult. Now let's become an adolescent or middle school student and try to fit in and have to fuss with those symptoms. So what I'm trying to get at is yes, they need emotional support, but you're looking at a big risk for non-compliance with the pharmacological intervention. So lots of education about the good that they're doing, and how it outweighs those undesirable side effects. Okay, appendicitis. I'm not sure if you cover this in your adults. Earliest symptom of an appendicitis is the periumbilical pain and vomiting. And the pain will be kind of diffuse. If you ask a child, where's your pain at? They're going to kind of rub all over their stomach when they're first presenting. As it progresses, that pain is going to localize to the right lower quadrant. If you ask the child if they're hungry and they say yes, that's a pretty good sign. It's not appendicitis, because along with the pain and some vomiting or nausea, they're going to have a general malaise type feeling. They're not going to feel good. They may or may not have a fever. If they do, it's going to be a very low fever. You don't want them to have a high fever. If they have a very high fever, it could be an indication that it has ruptured. So if they are a positive appendicitis, and these are usually identified, they'll do a abdominal x-ray first. Then they may do an ultrasound or a CAT scan, or they may do both, but they're trying to visualize the appendix. If you remember, it's that little tiny bubble of flesh that hangs off of the bowel of the large intestine that can capture content, and then they kind of get plugged up and it festers. So the treatment is surgery. You can anticipate them going to surgery. Anymore, it's a laparoscopic surgery. They may have one very small incision. If it has ruptured, you'll see a much larger incision because they have to irrigate and try to clean up in the abdominal cavity. Post-operative care, they're going to monitor I's and O's. Teach the family, teach the child about wound care, make sure their pain is under control. They're not to eat or drink anything until peristalsis returns. So that means until bowel sounds are heard. It says discharged home in 2 to 3 days. That's kind of iffy. If the appendicitis is caught early, they can be discharged within 24 hours. But if it has ruptured, you're looking at it probably a 5 to 7 day admission. And if it was very large, very close to rupturing, then you may see 2 to 3 days because they're watching for symptoms of peritonitis or abdominal infection. And again, if the appendix does rupture or perforate, you can anticipate IV antibiotics. They're going to be in PO until they actually have bowel movements. Ooh, went too far. Okay. I'm going to pause here, and then I'll pick up again with dehydration.